Welcome to my YouTube channel. In this video, I'm going to do anemia. Anemia is a condition in which the hemoglobin concentration is lower than normal. It reflects the presence of fewer than the normal number of erythrocytes within the circulation. As a result, the amount of oxygen delivered to body tissues is also diminished. Classifications of anemia. A physiological approach classifies anemia according to whether the deficiency is erythrocytes is caused by a defect in their production, which is hypoproliferative anemia, by their destruction, hemolytic anemia, or by their loss, bleeding. That's through bleeding. We start with the hypoproliferative anemias. The marrow cannot produce adequate number of erythrocytes. Inadequate production of erythrocytes may result from marrow damage due to medications, e.g. chloramphenicol. Those who are under chloramphenicol as their medication, this damages the bone marrows. Then we have chemicals, e.g. benzene. Then lack of factors, e.g. iron, vitamin B12, folic acid, and erythropoietin, an hormone that is responsible for the formation of red blood cells. Then we have necessary, which is necessary for erythrocyte formation. So iron deficiency anemia, these are a type of anemia. Iron deficiency. Causes of iron deficiency anemia are chronic blood loss, especially uterine or from GIT. Then increased demand during infancy, adolescence, pregnancy, and lactation. Then we have menorrhagia, malabsorption, gluten-induced and enteropathic gastrectomy. Then we have poor diet, also is a cause of iron deficiency anemia. Then we have clinical manifestations, which are the signs and symptoms, or in short, CM. Shortness of breath, particularly on exercise. Weakness, lethargy. Lethargy is just being tired. Palpitations. You feel that the patient can tell you that their heart is almost pumping out of the chest. Then we have headache. In older subjects, we have cardiac failure, angina pectoris. Angina is a strangling pain. This is mainly due to ischemia. Then we have confusion, visual disturbances in severe anemia. Then we have the signs, the general signs. We have pallor of mucous membranes, cardiomegaly, systolic flow murmur, especially at the apex. Then features of CCF and retinal hemorrhage, especially in the elderly. Then koilonychia, there is a NY there. Then angular stomatitis, dysphagia, pica. Pica is the craving for, like, let's say soap, stones, some soil. Then in children, irritability, poor cognitive function, and decline in psychomotor development. Then assessment and diagnostic findings for how to assess for anemia, anemias. We have history taking, bone marrow aspiration. There is complete absence of iron from the stores. The stores, we are talking about the stores in the bone marrow. That one is identified when bone marrow aspiration is done, the BMA. Erythroblasts are small and have a ragged cytoplasm. This is also identified after when BMA is done. Then we have MCV and MCH reduced in relation to severity of anemia. We have low HB, serum ferritin reduces in relation to the severity of anemia. Some infection and inflammatory conditions cause low serum iron levels and TIBC. The most definitive test is taking ferritin and HB levels. Then we have medical management. Investigate the cause and treat it. Administration of oral preparations. The best is ferrous sulfate. It's given in an empty stomach, QID, that is 4 times a day. If side effects occur, this can be reduced by giving iron with food or giving ferrous gluconate. For children, give elixir. Elixir is a drug. Oral iron should be given for at least 6 months. Parental iron, ferric hydroxide sucrose, iron dextran. The hematological response to parenteral iron is no faster than the adequate dosing of oral iron, but the stores are replenished faster. In intramuscular iron, iron dextran, cosmofer, iron sorbitol. Vitamin C facilitates absorption of iron, so you give vitamin C orally, the ascorbic acid. Then the nursing management, health education, especially in high-risk groups, e.g. pregnant women. Then we have iron-rich foods, e.g. meat, liver, beans, and leafy green vegetables. Nutritional counseling, health education on iron therapy, compliance. Nutritional counseling is to be given by the nurse because these are just nursing interventions. You assess. The first thing, the only thing that nurses should do, and the first and to be the first priority, is assess and then give nursing intervention. Then we have advise the patient to take iron supplements an hour before meal, since iron is best absorbed in an empty stomach. Then it can be taken with food in case of side effects. It can also be taken in the liquid form, though it stains the teeth. To avoid staining, advise the client or patient to use a straw or rinse the mouth with water after taking it. Antacids and dairy products should not be taken together with iron because they diminish its absorption. To prevent gastrointestinal distress, where more than one is prescribed a day, start with 1 tablet for few days, then increase to 2 and finally 3. This enables the body to adjust gradually to iron. Understood? Then treat side effects. If constipation, prescribe if there is constipation, you prescribe a laxative such as bisacodyl, arachis oil, and all those. Then another type of anemia, apart from the iron deficiency, we have megaloblastic anemia, characterized by large RBCs which are fragile and easily destroyed. Common forms of megaloblastic anemia are cobalamin deficiency and folic acid deficiency. Causes of vitamin B12 deficiency. Vitamin B12 is the cobalamin, formerly known as pernicious anemia. Vitamin B12 deficiency was formerly known as pernicious anemia. Intrinsic factor IF is required for cobalamin absorption. Intrinsic factor is produced by the cells in the walls of the stomach. So the intrinsic factor combine to vitamin B12 and makes it easily absorbed in the small intestines. So causes of cobalamin deficiency, we have faulty absorption after ileal resection or gastrectomy, Crohn's disease, deficiency of intrinsic factor as in long-term use of H2 histamine receptor blockers cause atrophy or loss of gastric mucosa from autoimmune disorders. Then nutritional deficiency, strict vegetarians, hereditary defects of cobalamin. Nutritional deficiency such as this occurs in those who are strictly vegetarians, then hereditary defects of cobalamin utilization. General symptoms of anemia: smooth red and sore tongue, mild diarrhea, vitiligo. Vitiligo is patchy loss of skin pigment, then premature graying of the hair, weakness, paresthesias of the feet and hands, altered thought processes, confusion, dementia. Dementia is also a clinical symptom. Folate. Folic acid deficiency also cause megaloblastic anemia, RBCs that are large and fewer in number. Folic acid required for RBC formation and maturation. Causes of folic acid deficiency: we have poor dietary intake of folic acid, malabsorption syndromes, alcohol abuse, increased demand as in pregnancy and chronic hemolytic anemia. Then we have hemodialysis. Excess folate urinary loss, active liver disease. This is an indicator of active liver disease and CCF, congestive cardiac failure. Drugs, anticonvulsants, and sulfasalazine. To note, folic acid deficiency clinical manifestations are similar to vitamin B12 deficiency, except neurological manifestations that are absent. Diagnosis of vitamin B12 deficiency: we have serum B12, serum B, where you take an assay of serum B12, where serum B12 is low, red cell folate also low, intrinsic factor antibody test. A positive test shows presence of antibodies that bind vitamin B12 intrinsic factor complex and prevent it from binding to receptors in the ileum, thus preventing its absorption. We have skilling technique to determine vitamin B12 deficiency. Skilling tests. Stage 1. You will get 2 doses of vitamin B12, the cobalamin. You will take a small first dose, a radioactive form of vitamin B12, by mouth. You will get a second large dose by a short 1 hour later. You will need to collect your urine over the next 24 hours and deliver it to a lab. The urine will be checked to see if you are absorbing vitamin B12 normally. If stage 1 is abnormal, stage 2 may be done 3 to 7 days later. Stage 2 includes you are given a radioactive vitamin B12 along with intrinsic factor. Intrinsic factor is a protein produced by cells in the stomach lining, as I had earlier said. The body needs it so the intestines can absorb vitamin B12 efficiently. Stage 2 of the test can tell whether low vitamin B12 levels are caused by problems in the stomach that prevent it from producing intrinsic factors. And if a stage 2 test is abnormal, a stage 3 test is performed, where stage 3 tests include this is done after you have taken antibiotics for 2 weeks. It can tell whether abnormal bacterial growth has caused the low vitamin B12 levels. Then you move to stage 4. This test determines whether low vitamin B12 levels are caused by problems with the pancreas. With this test, you will take pancreatic enzymes for 3 days, followed by a radioactive dose of vitamin B12. Intrinsic factor antibody test. A positive test shows presence of antibodies that bind vitamin B12 intrinsic factor complex and prevent it from binding to receptors in the ileum, thus preventing its absorption, as we are about to see. The normal results: urinating 8 to 40% of the radioactive vitamin B12 within 24 hours is normal. If there is a problem with the stomach's ability to make intrinsic factor, as stage 1 of the test will be abnormal and stage 2 will be normal. Both the stage 1 and 2 scaling tests will be abnormal in people who have problems absorbing vitamin B12 and intrinsic factor in the small intestines. Abnormal results may be due to biliary disease, celiac disease, which is the sprue. Then we have Crohn's disease, liver disease, and pancreatic disease. Medical management of vitamin B12, we have increasing the amount of folic acid in the diet and administering 5 mg of folic acid daily for 4 months. IM folic acid for people with malabsorption problems. Vitamin B12 replacement, with the replacement is hydroxycobalamin. Oral, you can give hydroxycobalamin orally or intramuscularly, the IM, to prevent recurrence of pernicious anemia. Vitamin B12 therapy must be continued for life. So nursing management: careful neurological assessment including test of position and vibration sense. Assess the patient's gait and stability, as well as the need for assistive devices, e.g. canes, walkers, and for assistance in managing daily activities. Ensuring safety when position sense, coordination, and gait are affected. If sensation is altered, the patient needs to be instructed to avoid excessive heat and cold. Because mouth and tongue soreness may limit nutritional intake, the nurse advises the patient to eat small amounts of bland, soft foods frequently. The nurse also may blend the foods. The nurse also may explain that other nutritional deficiencies such as alcohol-induced anemia can induce neurological problems. The patient must be taught about the chronicity of the disorder and the need for monthly vitamin B12 injections or daily oral vitamin B12 even in the absence of symptoms. If parenteral replacement is used, many patients can be taught to self-administer their injections. The gastric atrophy associated with pernicious anemia increases the risk for gastric carcinoma, so the patient needs to understand that ongoing medical follow-up and screening are important. Anemia in renal disease. The chance of developing anemia increases as kidney disease gets worse. A study has shown that anemia affected 28% of people with mild kidney disease and 87% of people with severe kidney disease. This anemia is caused by both a mild shortening of erythrocyte lifespan and a deficiency of erythropoietin, necessary for erythropoiesis. So diseased kidneys may not produce enough erythropoietin, the EPO, a hormone that regulates red blood cell production. Less erythropoietin, EPO, in turn means fewer red blood cells and their protein hemoglobin to deliver oxygen to your body's organs. If there are not enough red blood cells, your body does not get the right amount of oxygen, resulting in anemia. So other factors that can contribute to anemia in patients with kidney disease include iron deficiency, some vitamin B12, and the effects of poor nutrition or inflammation. So the degree of anemia becomes significant when the serum creatinine levels exceeds 3 milligrams per 100 mils. The erythrocytes are normal in appearance. Patients undergoing long-term hemodialysis lose blood into the dialyzer and therefore may become iron deficient. Folic acid deficiency develops because this vitamin passes into the dialysate. Management: we have recombinant erythropoietin. Erythropoietin in combination with oral iron supplements can raise and maintain hematocrit levels. Therefore, the hemoglobin should be checked frequently and the dose of erythropoietin titrated to maintain hemoglobin level at 11 to 12 grams per deciliter. So effects of untreated anemia in people who have both kidney disease anemia, anemia have an increased risk of death, stroke, or heart failure. So if you have kidney disease and anemia at the same time, you have an increased risk of death, stroke, or heart failure. Anemic children with kidney disease are also at an increased risk for hospitalization. The chance of early death is even higher for anemia sufferers who, in addition to kidney disease, have heart failure and or diabetes. So lack of oxygen makes the heart work harder, so the muscles in its left lower chamber get too thick. This condition is called left ventricular hypertrophy and can even occur in people with early kidney disease and increases the risk of people having a heart attack or even dying in the process of heart attack. So we have hemolytic anemias. The erythrocytes have a shortened lifespan, thus their number in circulation is reduced. This is hemolytic. You know, hemo means the destruction of the red blood cells by the liver. So fewer erythrocytes results in decreased available oxygen, causing hypoxia, which in turn stimulates an increase in erythropoietin released from the kidneys. The erythropoietin stimulates the bone marrow to compensate by producing new erythrocytes and releasing some of them into the circulation somewhat prematurely as reticulocytes. Yeah. So the reticulocyte count is elevated, the fraction of indirect, the unconjugated bilirubin is increased, and the supply of haptoglobin, a binding protein for free hemoglobin, is depleted as more hemoglobin is released. As a result, the plasma haptoglobin level is low. If the marrow cannot compensate to replace the erythrocytes, indicated by a decreased reticulocyte count, the anemia will progress. Inherited forms of hemolytic anemia, we have three. We have the sickle cell anemia, thalassemia, and thalassemia major, and hereditary spherocytosis, yeah, and G6PD deficiency. There are four. Acquired autoimmune hemolytic anemia. For the acquired, we have inherited, acquired, and then we autoimmune under the acquired, we have autoimmune hemolytic anemia, non-immune mediated paroxysmal nocturnal hemoglobinuria, microangiopathic hemolytic anemia, and heart valve hemolysis. We start with sickle cell anemia, a severe hemolytic anemia that results from inheritance of the sickle hemoglobin gene. Sickle hemoglobin gene acquires a crystal-like formation when exposed to low oxygen tension. The oxygen level in venous blood can be low enough to cause this change. Consequently, the erythrocyte containing HbS loses its round, pliable, biconcave disc shape and become deformed, rigid, and sickle-shaped. These long, rigid erythrocytes can adhere to the endothelium of small vessels. When they adhere to each other, blood flow to a region of an organ may be reduced. If ischemia or infarction results, the patient may have pain, swelling, and fever. The sickling process takes time. If the erythrocyte is again exposed to adequate amounts of oxygen, e.g. when it travels through the pulmonary circulation, before the membrane becomes too rigid, it can revert to a normal shape. Cold can aggravate the sickling process because vasoconstriction slows the blood flow. You know, when there is cold, blood flow is increased. So oxygen delivery can also be impaired by an increased blood viscosity with or without occlusion due to adhesion of sickled cells. Sickle cell anemia is the most severe form of sickle cell disease. Less severe forms include sickle cell hemoglobin, the SC disease, sickle cell hemoglobin D, SD disease, and sickle cell beta thalassemia. Sickle cell trait refers to carrier state for the sickle cell hemoglobin C, the SC, that is the sickle cell trait. With that, we move to the clinical manifestations. Symptoms and complications result from chronic hemolysis or thrombosis. Sickle cells are rapidly hemolyzed and thus have a very short lifespan, 10 to 12 days. The normal cell have a lifespan of 120 days. You can see the reduction in the lifespan. So signs and symptoms, we have anemia. Hemoglobin values are 7 to 10 grams per deciliter. Then we have jaundice. The bone marrow expands in childhood in a compensatory effort to offset the anemia. You find that if it's a child, the face is swollen. This is because of bone marrow expanding. Then we have tachycardia, cardiac murmurs, and cardiomegaly. The heart tries to pump to compensate for the need of oxygen in other organs such as on vital organs such as the brain. Then we have dysrhythmias and heart failure may occur in adults. Hypoxic damage or ischemic necrosis of body organs, especially the spleen, the lungs, and central nervous system. Unusual susceptibility to infection, particularly pneumonia and osteomyelitis. The clinical expression of HBSS is very variable. Crisis may be vaso-occlusive, visceral, aplastic, or hemolytic. Painful vaso-occlusive crisis. Most frequent. These painful vaso-occlusive crises are most frequent, precipitated by infection, acidosis, dehydration, or deoxygenation. Infarcts can occur in bones, hips, shoulders, and vertebrae are most affected, lungs and spleen. The most serious crisis is of the brain and the spinal cord. Doppler ultrasonography detects abnormal blood flow indicative of arterial stenosis, and this predicts stroke in children. Yeah, you have to get that. Can be largely prevented by blood transfusion. Hand-foot syndrome is the first presentation of the disease. Yeah. Then visceral sequestration crisis, caused by sickling with organs and pooling of blood with a severe exacerbation of anemia. Acute sickle chest syndrome in the cause of death after puberty. It presents with dyspnea, falling arterial blood, falling arterial blood oxygen, then chest pain and pulmonary infiltrate on chest x-rays. Treatment is with analgesia, oxygen exchange transfusion, and ventilatory support. splenic sequestration in infants, presence with an enlarging spleen, falling HB and abdominal pain. Transfuse and monitor at regular intervals. Attacks tend to be recurrent and splenectomy is often needed. Aplastic crisis, or due to infection with the aplastic crisis occurs due to infection with the parvovirus or from folate deficiency, characterized by sudden fall in HB, requires transfusion. There is a fall in reticulocytes with this aplastic crisis. Then we have hemolytic crisis, increased rate of hemolysis, fall in HB, rise in reticulocytes, accompany a painful crisis. Other clinical features, we have ulcers of the lower legs due to vascular stasis and local ischemia, splenomegaly in infancy and early childhood, but later is reduced in size as a result of infarcts, the autosplenectomy, pulmonary hypertension detected by Doppler echocardiography, and increased tricuspid regurgitant velocity. Lab findings, we have sickle cells. Sickling test is positive. The blood is deoxygenated with methionine and that HB electrophoresis, and in HBSS, no HBA is seen. Then treatment, prophylactic treatment of anemia. We have daily folic acid replacement to maintain the supply required for increased erythropoiesis from hemolysis, good general nutrition and hygiene. Then we have pneumococcal, meningococcal vaccine should be given, as well as oral penicillin. Hepatitis B is blood transfusion. Hepatitis B vaccine as blood transfusion is sometimes needed. So we have the crisis: treat by rest, worth rehydration by oral fluids and intravenous normal saline, 3 liters in 24 hours, and antibiotics. Then analgesia, as the appropriate level should be given. Suitable drugs are paracetamol, NSAIDs, and opiates, e.g. continuous subcutaneous diamorphine. Blood transfusion is given in very severe anemia. Exchange transfusion may be done in case of neurological damage, visceral sequestration crisis, or repeated painful crisis. Peripheral blood stem cell transplant may cure sickle cell anemia. Transfusions, pharmacologic therapy, hydroxyurea, which is effective in increased fetal hemoglobin, that is hemoglobin F levels in patients with sickle cell anemia, thereby decreasing the form of sickle cells. Patients who receive hydroxyurea appear to have fewer painful episodes of sickle cell crisis, a lower incidence of acute chest syndrome, and less need for transfusion. Arginine has anti-sickling properties and enhances the availability of nitric oxide, the most potent vasodilator, resulting in decreased pulmonary artery pressure. With that, move to supportive therapy, where we give pain management, adequate hydration, and supplemental oxygen. With that, we move to nursing process. The patient with the sickle cell crisis, you first assess. Careful assessment of all body systems is necessary. Particular emphasis is placed on pain, swelling, and fever. Nursing diagnosis. Based on the assessment data, major nursing diagnosis for the patient with sickle cell crisis may include acute pain related to tissue hypoxia due to agglutination of sickle cell within blood vessels, risk for infection, risk for powerlessness related to illness-induced helplessness, deficient knowledge regarding sickle cell crisis prevention, planning and goals, relief of pain, decrease incidence of crisis, enhance sense of self-esteem and power, absence of complications. Nursing intervention, we have to manage pain, relaxation techniques, where we use relaxation techniques, breathing exercises, and distraction, support of swollen and painful joints. Then preventing and managing infection, we have to prescribe antibiotics. The prescribed antibiotics should be initiated promptly, and patients should be assessed for signs of dehydration. Then promoting coping skills, nursing care that focuses on the patient's strength rather than deficits can enhance effective coping skills. Providing the patient with opportunities to make decisions about daily care may increase the patient's feeling of control. So minimize deficient knowledge. Patients with sickle cell anemia benefit from understanding what situations can precipitate a sickle cell crisis and the steps they can take to prevent a diminished success crisis. Keeping warm and maintaining adequate hydration can be effective in diminishing the occurrence and severe attacks. With that, I think I'm done. Not that I think I'm done with the video. Just like, subscribe, and with the last part, I'm giving you the potential complications, which are the cerebrovascular accidents, anemia, acute and chronic renal failure, heart failure, pulmonary hypertension, and acute chest syndrome, impotence or priapism, poor compliance, substance abuse related to poorly managed chronic pain. Yeah.